Greetings and welcome to the telephone and web education program, Chronic Myeloid Leukemia, Current Strategies and Insights. At this time, all participants are in a listen-only mode. If you are participating by telephone and require assistance during the teleconference, please press star and 0 on your telephone keypad. It is now my pleasure to introduce your moderator, Lizette Figueroa Rivera. Thank you, Lizette. Please begin.
Hello, everyone. I'd like to welcome all of you, especially today as we unite on World CML Day, which is observed annually on September 22nd to raise awareness for CML, with the date symbolizing the Philadelphia chromosome translocation between chromosomes 9 and 22, which cause this disease. The day's goals nationally and internationally include empowering patients and caregivers, promoting understanding of CML biology and treatments, highlighting access issues, and fostering empathy and support within the CML community. Thank you so much for joining our conversation today about the latest advances in chronic myeloid leukemia. The Leukemia and Lymphoma Society is now Blood Cancer United. Blood Cancer United is an evolution, not a new beginning, that will help us meet our bold goal to enable patients with blood cancer to gain more than 1 million years of life by 2040. With the name Blood Cancer United, we can now reach more people who need us, people affected by all 100 plus types of blood cancer. Our mission is not changing, and we will continue to be a global leader in blood cancer research, support, and advocacy. With your help, we've invested more than $1.8 billion in groundbreaking research supporting many of today's most innovative approaches to treatment, helping those with blood cancer not only survive, but also thrive. Thanks to treatment breakthroughs pioneered with Blood Cancer United support, patients with CML can expect a similar lifespan to the general population. Now, the treatment landscape is evolving to focus on treatment-free remission and identifying those patients who are high risk at the time of diagnosis. In addition, Blood Cancer United is helping to explore how the immune system can be recruited to further enhance therapy for CML patients. Blood Cancer United is at the forefront of precision medicine and will continue to accelerate impactful research to improve the quality of life of patients with CML and help make long-term treatment-free remission a reality for more patients. Please continue to inform us of what you need during this time, and please continue to let us be here for you. Closed captioning is available for this presentation. The closed captioning icon can be found on the gray toolbar on the left side of your screen. Support for this program is provided by Novartis Pharmaceutical Corporation. If you're participating today by computer, Dr. Thompson's slides will be displayed via video. You may also view or print the slides from our website at bloodcancerunited.org/programs, or you can download and print the slides from the Materials tab on this program's web platform. Following the presentation, we'll take questions from the audience. It is now my pleasure to introduce Dr. James Thompson, Associate Professor in the Department of Medicine and Associate Chief Medical Information Officer, Medicine Diplomate at Clinical Informatics at the ABPM at Roswell Park Comprehensive Cancer Center in Buffalo, New York. Dr. Thompson, I'm privileged to turn the program over to you.
Thank you, Lisette. So moving into the program, I have no financial disclosures to discuss. So I'm going to be talking about just an overview of CML. I know there's probably many people on this call who are well-versed in all of these different details, but in case there are those who are just kind of starting on their journey, I'll just start with really kind of the basics of what we think about, because also this really, this kind of frames what what we're talking about for therapy. So most patients present in what's called the chronic phase of CML. There's no increase in blasts, and there are no additional chromosome changes beyond the 922 translocation. The next one to really talk about, because it's the one that we care about the most in terms of preventing the true adverse consequences of CML in somebody who isn't appropriately treated, is what's called blast phase or blast crisis. So that's a change in what's happening in the disease where there's a block in differentiation, so the cells don't grow up appropriately the way they do during chronic phase, and they just stay as this blast stage. And so it's much more like an acute leukemia. And unfortunately, blast crisis is frequently a fatal event because we just cannot get people under control. And then we talk about accelerated phase, and really accelerated phase is kind of a conceptual thing. It's really those patients who are showing us elements that suggest they are at risk of going to blast crisis, but they're not yet in blast crisis. And so for each of those phases, we have different goals of therapy. So the primary goal in chronic phase is don't let it get to blast phase. And as Lizette mentioned at the top, more and more nowadays, potentially the goal can be to get people to what's called a treatment-free remission. I'll be talking more about that later. When someone is in blast phase, the goal is to get them back into chronic phase. And many of those patients, we do think about a donor bone marrow transplant as part of their overall therapy. And for those in accelerated phase, again, it's to get them back into chronic phase. And sometimes with accelerated phase, we will talk about use of a transplant, certainly something to be considered, but not in all cases. Okay, so next up, I just want to go through, there's a lot of jargon that we use, but it's important in kind of understanding where things are. In this table, you can see the top three really are kind of the levels at which we expect somebody to go through from their initial diagnosis to potentially getting to the point of a treatment-free remission. The first level of response that we would expect to see is to get to what's called complete hematologic response. So that means that their blood counts are normalized with the white count under 10, platelets under 450. They're not showing any immature cells floating around in the blood. And if somebody's spleen had been large at presentation, that's gotten smaller. They're not having any other signs and symptoms of the disease. So that's typically associated with about a 10-fold decrease in the burden of disease. The next level of response we talk about is a cytogenetic response. And what we mean by a cytogenetic response is looking at the cells in the bone marrow and counting the chromosomes that are there. Typically at diagnosis, if you look at a bone marrow of a patient with CML, just in chronic phase, 20 out of 20 of the cells that you type will have the Philadelphia chromosome. If you see a complete cytogenetic response, then that means that none of the 20 cells show any evidence of the Philadelphia chromosome. And a partial response is something less than all of the cells. To be a partial response, it needs to be down around the level of no more than about 7 or so of the 20 cells. That's the next level, and that's about 100-fold drop in the amount of disease is where you get to a complete cytogenetic response. And then for the different levels of molecular responses, when we talk about an early molecular response, that's just getting under 10%. And again, that's typically not going to be at as deep of a response as you would expect to see with a complete cytogenetic response. If you get a major molecular response, then that is definitely associated with a complete cytogenetic response. And then we talk about a deep molecular response, which is about a 10,000-fold decrease in the amount of disease. So if you start at 100%, you drop down to 0.01% or less. That is the level that is consistent with, that is the level that is required for us to consider looking at a treatment-free remission for a patient. And again, we'll be talking about that a little bit more. And then finally, when we talk about relapse, you can have relapse from any one of these stages. So if somebody's had a complete hematologic response and then loses it and starts having an elevated white count from their CML, that's a hematologic relapse. If they had a complete cytogenetic response, but now are showing some Philadelphia chromosome positive cells on their bone marrow, that would be a cytogenetic relapse. And if somebody has gotten to a deep molecular response and then loses their major molecular response, we would call that a molecular relapse. Typically, we talk about a molecular relapse being anytime there's a tenfold increase. That's what 1 log means, a tenfold increase in where their transcript levels were. So say somebody had 0.005 and now they're up to 0.05, that would be a tenfold increase. Okay, so just talking about the biology of CML, again, this is for many listeners, this may be sort of going over the basics, but it's important for understanding kind of what drugs we use and how we use them. So this Philadelphia chromosome, the 922 that we spoke of earlier, is it gets set up when part of chromosome 22 crosses over to part of chromosome 9, which then generates this new protein, this new BCR-ABL protein. So the top end of the protein is no longer what it started with. And that top end, that BCR portion of the BCR-ABL, its normal function is to go and find other things that look like it and stick to them. And that's the usual way that our bodies control turning on and turning off the ABL portion, is by bringing 2 copies of ABL next to each other. And so the BCR-ABL just turns them on all the time. And so there's all sorts of things that get turned on downstream of that. The drugs that we use, most of the drugs that we use to treat CML, they rely upon interrupting the function of that ABL portion. So you see that ATP that binds into that little pocket there in the BCR-ABL. The ABL portion needs that ATP there to then be able to stick phosphates onto whatever it's targeting, and it's adding those phosphates that makes things happen. Drugs like imatinib, and really all of the drugs that we use other than Asciminib, will bind into that pocket and kind of compete for that space. And so if they're bound, then ATP can't be bound and the ABL can't do what it needs to do. So at this point, not so new, but the newest drug on the block is a drug called Asciminib. So it got approved back in 2021 as a new drug. Since that time, it's now gotten approval even in the frontline setting. So it's now FDA approved to be used as the first drug for some patients where that choice is made. It works differently. So one of the things that happens in the changes to the ABL, the normal ABL, if you see in that left panel there, there's that squiggly yellow line is what's called a myristoylated N terminus, which means just the front end of the protein. That modified part of the protein is specifically designed to kind of slot into a different part of the protein that then forces it down into an inactive shape. But since that only gets added on the top end that gets replaced by BCR, as you can see in the middle panel, that sort of self-inhibition doesn't happen in BCR-ABL. And so Asciminib is designed to be like that little squiggly myristoylated N terminus, and slot into that socket and force the protein to go inactive, even though it's not doing that itself. And what's really important about that is that's a completely different location in the protein from where all the other drugs are working. And so mutations that happen that will make that version of BCR-ABL resistant to this drug or that drug often the Asciminib will work on them because it's coming into a different spot. And additionally, since Asciminib works at a different location from all of the other drugs, there's not a lot of point in giving somebody both imatinib and dasatinib, because both of them will act on that pocket of ATP, and they'll just get in each other's way trying to inhibit it. But you can combine imatinib with Asciminib, or imatinib. Oh, sorry. I switched my slide over, but didn't push it over. So this is the pocket I was talking about. So dasatinib and imatinib, or any of the other ones other than Asciminib, will all try to get to that one ATP pocket, and they will get in each other's way. So the Asciminib works by different mechanisms, and so you can combine Asciminib with imatinib or dasatinib, nilotinib, any of those, for more effective therapy. Okay, so talking about dosing and side effects on Asciminib, since it's a newer drug. In the studies that were done, it was always 40 milligrams twice a day. What the FDA approved, however, included the use of 80 milligrams once a day, which is definitely a more convenient way of dosing the medication, and it certainly seems to work just as well. One of the more bothersome aspects of dosing with Asciminib is that you have to dose it with nothing to eat for 2 hours before you dose, and for 1 hour after. Overall, Asciminib really does seem to have many fewer side effects from the other CML TKIs, and that's probably because the way it works. Many different proteins, again, going back to this little diagram here, many different proteins, not just c-Abl and not just BCR-Abl, have this ATP have a pocket to bind ATP that then lets them act to add phosphates onto things. So there are many different kinds of tyrosine kinases. And, for example, imatinib also works on a tyrosine kinase called c-Kit. And so there are off-target effects of each of these drugs. The mechanism for Asciminib is a lot more particular, and so there tends to be a little less spillover to other things that it inhibits. The kind of side effects we do see with it are low blood counts, potential for increase in liver enzymes, and various GI issues. Overall, in the initial studies that got it approved as a third-line therapy, so having failed 2 other things, showed that compared to bosutinib, Asciminib was much more effective in the 3rd line, and especially in the 4th and 5th line, it was far more effective than bosutinib. Okay, so in terms of how we measure people's responses, folks may or may not have seen what I refer to as red light, green light, go, which is from the NCCN guidelines, just a grid laying out kind of where things are. So the key takeaway points from this is that for those who are just starting on therapy, the measurement of how people are doing at 3 months can potentially offer up some warning signs. So that's the yellow, but we don't necessarily make any changes in therapy at the 3-month mark. If people are still at that greater than 10% molecular result at the 6-month mark, then that definitely is a problem, and that definitely will need some management. But anybody who is under 10% is in what we refer to as the green zone for the 3-month and 6-month marks. And at the 12-month mark, where we now sort of refer to that as orange. So the reason for that is that going back to those definitions of different levels of response. So what we know historically is that those who have a complete cytogenetic response, so no Philadelphia chromosome positive metaphases in their bone marrow, will not progress to blast crisis. And again, that's the key thing that all of our therapy is wrapped around, is that if we can get people to a point that they've got a molecular level that's equivalent to a complete cytogenetic response, which is a level less than 1%, then we know they're going to have a complete cytogenetic response, and we know that they're going to be under good control. But our data about the molecular responses is really by reference to the cytogenetic responses. And so getting to that orange zone, folks who are in the orange zone, so they're greater than 1%, they may have a complete cytogenetic response. And so if you look at the bone marrow in that patient and they have a complete cytogenetic response, they are still fully protected from going to blast crisis, even though their molecular is over 1%. So that's the reason for the orange. So again, in most circumstances, if somebody's above 1% at the 12-month mark, we will make a medication change and try to drive them lower. But if they're at the 12-month mark and they've had a number of different medications that they've had problems with, sometimes it will be appropriate to then do a repeat bone marrow assessment, get formal chromosome analysis from that bone marrow, and if all 20 metaphases have no evidence of the Philadelphia chromosome, let's say patient has 3%, 4% as their number, then for them, 3% or 4% is still consistent with being safe from proceeding to blast crisis. The light green segment at the 12-month mark, that has to do with what the goals of therapy are. So for a patient who has been having issues with treatment and really, they're content to protect themselves from going to blast crisis, but they don't think that they're ever going to be able to come off the drug, then light green can be appropriate especially for some older patients as well. Trying to get to a treatment-free remission may be kind of more than what that patient is looking for. Especially for younger patients, especially for younger women who wish to become pregnant, the goal at 12 months really is to get down less than 0.1%, and ideally down to at least 0.01% to be able to get them to a treatment-free remission. And so for those patients, being above 0.1% at 12 months would be out of their range of where their goals are, and they would need to push their therapy to be more aggressive. So, okay, we keep talking about treatment-free remission. So what is a treatment-free remission? So if we have been successful in suppressing all of the CML stem cells that are able to regrow CML, it's sometimes possible to stop treatment and still stay in that green zone. Of patients who are eligible for us to try a treatment-free remission, about 50%, in some studies, 60% of folks who we try that in are able to stay off treatment. Of those who do need to start treatment again, just about 100%. I think I've seen 2 or 3 reports in the literature of folks who didn't get right back into remission. So there's, in many ways, there's little downside to trying a treatment-free remission. It is just possible that you try it and then you do have to go back on therapy. In both the last study, which is a study that we participated in, and really now this has been codified into the NCCN guidelines for doing a treatment for remission. The requirements to be eligible is that you have to be on therapy for at least 3 years. And so for those who have gotten down to a level of 0.01 or lower in less than a year from starting on therapy, they need to spend longer than 2 years at that lower level because they need to be on treatment for at least 3 years. So however long it takes for you to get down to the 0.01%, that you need to be down at that level for at least 2 years. Once somebody makes the decision to attempt a treatment-free remission, they should be assessed They should be assessed monthly for the first 6 months. Then they should be assessed every other month for the next 6 months. And then they should go back to what should be the standard of monitoring on treatment or not of checking the molecular levels every 3 months. And the current guidelines are to restart treatment if somebody has a level that is greater than 0.1%. And just stepping back to comment on the reason we do this monitoring this way with this sort of frequency is that of those who will need to go back on treatment, most show their numbers that they need to go back on treatment within the first 6 months, and nearly all the rest show up within the next 6 months. So that's the reason for that frequency of monitoring. The folks who are going to need to go back on, we're going to be, during the period of time when most folks need to go back on, we're going to be monitoring monthly. And during the period of time when most others who need to go back on end up needing to go back on therapy, we're going to be checking every other month. Okay. So as part of the last study, one additional piece that we did is we looked at those who coming into the treatment for remission. So for the testing, for the standard lab testing that was done right before they came off treatment. For those where that testing came back to say, nope, can't see any BCR-ABL there at all, we then did a research test, something called digital droplet PCR. It's a way of doing the testing for the BCR-ABL that's just much, much more sensitive. It gets down to like 0.0001% in that range. And so for those who were negative when they came in and the digital droplet was negative, that's that bottom dark gray line. They had only about 10% risk of needing to go back on. 90% of those folks were able to go off and stay off. Interestingly, for those who were not detectable at the time of, those who were not detectable at the time by standard testing, not detectable by standard testing at the time they went off, if their digital droplet was positive, they were a little bit more likely to need to go back on treatment. Okay, so they had about a 60% rate, or more like 70% rate of needing to go back on. So only about 30% success rate. Whereas the success rate for those who were detectable from the get-go was about 60%. Sorry, the success rate was about 40%. About 60% needed to go back on. Now this would be a great test to be able to do, to be able to offer to my patients to say, look, you've been negative. What's the chance that, do you have this other testing coming in that suggests that you're really unlikely for this to come back? Unfortunately, this is a very complicated test to run. It's much more manageable when batched amongst hundreds of patients on a study and run once, as opposed to just kind of running it when it comes into the clinical lab. So at the moment, I certainly do not, and talking with many of my colleagues, no one currently has clinically available this digital droplet test. So it's something folks in my center we're definitely pushing towards getting, but we do not currently have it available for checking people. Okay, the other takeaway point from the original last study is that where people are at 3 months is a very strong predictor of where they're going to end up. So if somebody was detectable at 3 months at the time they started and they were detectable at 3 months, there was a very high probability they would need to go back on. So those folks only had about a 20% overall response rate. Overall success rate. About 80% of them need to go back on. If somebody was detectable at baseline, but then they became undetectable, or if they were undetectable at baseline and they were detectable at 3 months, those folks had more like an 80% success rate. And those folks who were undetectable at baseline and they were still undetectable at 3 months, they had a very good success rate. So for those who come into an attempt at treatment-free remission undetectable, if they're still negative at 3 months, is a very, very good chance that they will not need to go back on treatment. Now, as part of the last study, it wasn't published originally with the last study. These are some follow-on studies that we published. We did a lot of surveys of what are called patient-reported outcomes. So this is a way of going directly to you, the patient, and asking, how are you functioning with this? Do you have any issues here? Do you have these symptoms? Do you have those symptoms? So looking at the symptom scores before people came off treatment, then after they've been off treatment for a while, and then also, again, if you think about it, about half of the folks ended up needing to go back on treatment because of molecular issues. So we can then also track, well, what happens to the symptoms after people restart therapy? And so what's interesting here, so what you see on the left-hand side are the curves from before stopping the TKI till afterwards. You can see that this particular oh, I'm sorry, I'm not putting that out to you. So there we go. Now you can see the graph. That on the left-hand side, you'll see that graph sort of shows the overall scores of what's called sort of social participation or social functioning. Those got better over time in those who had stopped their TKI. And then you can see in the right-hand grid, after people restarted TKIs, it then dipped down for a bit. So people get real improvements in various important parts of their quality of life by being able to stop drugs. Okay, so what about those who can't do a treatment-free remission? So we in the Cure CML Consortium, we are exploring a study design in which we do what's called dose optimization. So tailoring to each person based on the trends of what their moleculars have been doing. Taking them, so if somebody's on 50 milligrams of dasatinib, drop that down to 20 milligrams, drop that down to 10 milligrams, and just keep taking the dose as low as we can while keeping their moleculars in good control. And so even if those folks haven't been able to be off treatment completely, can we optimize their dose to be as low as possible to still keep them in good control, and so minimize their symptoms? So that's been through one round of NIH funding, got scored back, and we're in the midst of resubmitting it to address the comments. As you might understand, if you sort of know the economics of clinical research, this is really the sort of study that we need to get government funding for, because no particular drug company is going to want to fund people figuring out if they can use less of their drug rather than more. So that's the sort of thing you need NIH funding for. And so we will see what that brings in. And then finally, what about folks who have run the gamut and gone through all of our different TKIs? What's available for those patients? So donor bone marrow transplant, which was historically our only manageable option before imatinib came on the scene, that was the only treatment that had a strong success rate. Interferon would lead to a good long-term outcome in a subset of patients, but transplant was really the only thing that could truly get somebody's CML under control before imatinib and all the other drugs that followed it came on board. Lately, there have been some substantial advances in the methods for doing transplant that provide a very high rate of success in CML patients with a much lower rate of side effects. So going to transplant for CML, it's rare, but it is a very useful treatment method in those patients who have failed other drugs. sometimes the reason folks are failing all the different drugs is just that their bone marrow really needs BCR-ABL, the normal BCR-ABL, to function. So the drugs that we use, again, going back to that little graph there, imatinib binding into that part of the BCR-ABL that's got the ATP binding pocket, that is the same pocket in the normal ABL that hasn't been taken over by BCR-ABL. And so all the normal things that ABL does in somebody's body, imatinib or dasatinib or nilotinib and asciminib, all of them will inhibit those things. And so while it is rare that the ability to make blood cells depends upon c-ABL, in some patients, that is what we see. And so every time we put on any one of these drugs in those patients, it will cause them to drop their counts. And so in those patients, very often, the only way we can address that is to do a donor bone marrow transplant, because the overwhelming likelihood is, since it's very rare for people to have their bone marrow be dependent upon ABL, in those instances, it is as soon as you get somebody else's bone marrow in place, then that patient will be able to tolerate the drugs without their counts dropping too low. And even if the transplant wasn't getting rid of the CML, we'd be able to use those drugs then to get rid of the CML. All right, so that is the end of my prepared slides. So I will go ahead and hand over for the question and answer session.
Well, thank you so much for the great information, Dr. Thompson, especially on World CML Day. As you mentioned, it's now time for our question and answer portion of our program. And for everyone's benefit, if you can please keep your questions general in nature without many personal details so that Dr. Thompson can provide answers that are general in nature. Operator, can you please give instructions to our telephone and web audiences?
I'm happy to, Lizette. Thank you. To participate in the Q&A session by phone, please dial star and 1 on your keypad. If you are joining us by web, simply put your question in the Q&A box and then hit submit. We will take questions in the order they are received, and we can only take one question per person. Once a phone question has been voiced, you will be transferred back to the audience line. Again, to ask a phone question, please press star followed by the digit 1 on your keypad, or simply put your question in the Q&A box and then hit submit.
Thank you. And we'll take the first question from our online audience. Dr. Jen is asking, are you seeing problems in some of the longest term patients, those who have been taking the TKIs since the earliest days around the year 2000? Survivors are 20 to 25 years out now. So are there any kidney or neurological and any other concerns?
So that is a great question. We have not been seeing, I mean, we have some patients who are very, very long-term on therapy. We've not been seeing anything that's kind of, jumps out at us. I mean, there's other drugs that we have people on for a very, very long time. Like, for example, hydroxyurea. Like, if people are on that for 10, 15, 20 years, we start to see these chronic leg ulcers. Again, not in every patient, but it's sort of a common thing to see in those patients. I can't say that there's been anything specific. You mentioned kidney issues. Definitely each of these drugs can cause issues for kidneys in individual patients, but that seems to be more something that will crop up in the first few years rather than a long-term effect. But again, the potential for that is absolutely there. And that, again, is why our current focus in the field is first to get people to treatment-free remission, because if you can get them to a treatment-free remission, then there's no concern about any long-term effects of the drug you've got somebody on. And then if you can't get somebody to a complete treatment-free remission, then to reduce the dose of the drugs as much as possible, again, to try to minimize the potential for those side effects.
Thank you. And we'll take the next question from our telephone audience, please.
Zella from Florida. Please go ahead. Your line is open.
Yes, I was just wanting to make sure I understood. If you get the CML down where it's almost undetectable in the blood and it's there long term, and you go into treatment free, and the CML does come back, is it not more aggressive when it comes back than it originally was?
Excellent question. No, that's really not what we see. And again, that's certainly in our initial work towards treatment-free remission, that was a concern, at least in theory. You know, would it come back, and would it sort of be more aggressive or more difficult to treat? The best analogy I can give towards this is, or not really analogy, but just sort of an explanation of why we see what we see. So in a scenario where we have, you know, we'll just say drug X rather than talking about a particular drug. So patients on drug X, and that has completely shut down their BCR-ABL. The BCR-ABL is not giving any advantage to the cells that have it because it's completely shut down. So we don't see the BCR-ABL showing up very much. If we then take that drug away and it shows us that it was still there, it was just suppressed by the drug that they were on. As soon as it shows up, we put that drug back on board, it's going to respond again. The only reason it started showing up again was not because it had developed some ability to get around the drug. It showed up again because we stopped giving the drug. And as soon as we give that same drug back again, they get back under control. Yes, in theory, there would be concerns that, you know, letting CML be active allows various things to happen. But again, new mutations to develop. I mean, that's the biology that gets us to blast crisis. That does not seem to happen if the level is less than 1%. And so by using as a trigger, getting to a level of 0.1% or 10 times lower than that level as the reason to get somebody back on treatment, that appears to minimize any chance that their disease will change on us. Again, you know, 2 or 3 times in the history of people doing TFR, this has been seen where somebody has had their CML come back in a way that wasn't able to get under control. But that has not been the experience for the vast majority of patients.
Thank you. The next question comes from our web audience, Doctor. Margaret is asking, how does my doctor choose which drug I take? I just went off Sprycel and now I'm on to Cigna. They think the Sprycel was putting fluid around my heart, but there's so many other drugs. So how do you really figure out which one is the best?
Right. So what you just described, the fluid around the heart with dasatinib, that is probably the most common reason that we have to change somebody from dasatinib to another drug. So that's definitely not specific to you. We frequently see that. You know, the particulars as to which drug to use, each of them has its own sort of spread of side effects. And so to give an example, if I had a patient come in who already had a lot of trouble with fluid buildup, and you know they've chronically had fluid built up in their ankles, and you know they've been spending years trying to deal with it before they ever develop CML, I would probably be less interested in getting them started on dasatinib given the side effects that dasatinib leads to. Likewise, with nilotinib, we can see issues with, especially in patients over the age of 60, in what's called peripheral arterial occlusive disease. So blocks in blood vessels in the heart, blocks in blood vessels supplying blood to the legs, things like that. So, you know, in an older patient, I might not lean towards nilotinib as a drug to use. Each of them has their own advantages and disadvantages. I would comment that while we are participating in a research study of the use of Asciminib as an upfront drug, I have not been using that as my first-line drug in patients so far. And the fact that we have the research study has sort of saved me from needing to answer the question as to whether or not that would be my first choice. Right now, for patients who can't go on the study, my first choice is dasatinib, typically at a lower dose of 50 milligrams rather than the standard 100 milligram dose. That does seem to cause less in the way of fluid buildup. But for those who fail the dasatinib, I am more and more often going to Asciminib as my second line, again, because it really does seem to have a much lower side effect profile for most people. And so if I'm switching because of symptoms, that's often what I will reach for.
So at this time, you don't have to start a patient with the oldest medications that have been approved. You can start someone.
Okay, that brings up an excellent point, which is more the economics of this. So depending upon one's insurance plan, it may be required that you start on imatinib. And I'm expecting soon, because now dasatinib is also off patent. I'm expecting soon, as the generic dasatinib really drops down to the quite affordable level that generic imatinib has reached, that insurance companies will be requiring that first. And we definitely know historically that those who respond well to imatinib respond very well. And getting back to that prior question about people who've been on treatment for 20 plus years, those people have been on imatinib for 20 plus years because they've gotten really good response from it. So it's not that imatinib can't get good responses. And so I understand when an insurance is going to, for purposes of cost containment, want us to start with imatinib. And then if that fails, then switch to something else. And I think that's a reasonable approach. I mean, certainly in all of the studies that have looked at the, there are head-to-head studies that show that imatinib versus dasatinib will drive things lower faster. Imatinib versus nilotinib will drive things lower faster. And all of those studies, the survival outcome of the folks who started on imatinib was exactly the same. They were excellent survival, excellent overall responses. It just has to do with the speed with which you get there. And so I think it is definitely medically appropriate to be requiring a cheaper option. Again, where I hope we will end up sooner rather than later is if generic dasatinib really drops down to comparable cost to generic imatinib, then I think there's really no argument for imatinib over dasatinib in most patients. Again, if I had a patient who had many, many medical complications, and especially had problems with fluid overload, I might use imatinib over dasatinib in that patient. So there are arguments for, honestly, each of the drugs up front, depending upon the individual medical situation.
Thank you, doctor. And we'll take the next question from our telephone audience, please.
Lisa in California, please go ahead. Your line is open.
Hi there. I've been on imatinib for 23 years, and earlier this year attempted. Thank you. Yes, I've been very well. Although when I tried TFR earlier in the year, seeing the doctor monthly, my symptoms, withdrawal from the TKI became pretty intense. It was difficult to manage the inflammation and pain in all my joints. And also after the third, going into the fourth month, I continued to increase with transcripts up to almost a full log increase. So I requested to be taken off the TFR due to those symptoms. And within a month, I was back down to PCR negative. And it's taken about the same amount of time, 3 to 4 months, to relieve my symptoms. But I was wondering why some might, in fact, be harder on those withdrawal symptoms than others. And maybe it was for 23 years of imatinib, it was not easy for my body to adjust without. Thank you.
Yeah, I think exactly. I think being on 23 years probably drove a lot of it. So from some of the details that you gave, you bring up a very important point. And actually, let me go back here. So right here, this point, restart treatment if you reach 0.1%. So there is no reason to react to even a tenfold or higher increase. I mean, if you're starting at 0.003, you can come up to 0.03, you can come up to 0.09, and you're still okay. That's still going to be safe. So the amount that it rises when you're doing a TFR, that isn't so critical. Again, what you were describing in terms of the withdrawal symptoms, yes, that can be very bothersome for some, and it really can drive, it really can make it difficult for people to continue. That said, in my experience, that is generally something that if you can get through, and it sounds like you spent 3 months, and maybe that's about as far as I would try to go with somebody as well. I would say in a situation like that, I would recommend trying to get to the lowest possible dose of the imatinib that lets you avoid withdrawal symptoms, to then also minimize any long-term toxicities of the imatinib. Because from the sounds of it, I think, your disease is relatively well under control and should stay under control even at a lower dose of the imatinib.
Yes, and thank you for the question. So there are some folks that get withdrawal symptoms when they get off of the medication and some that don't?
Yep, correct.
Okay.
There's some that do, there's some that don't. And for many, it really does have to do with just kind of rewiring things. The way to really think about the withdrawal symptoms from any of these drugs, again, gets back to that point I was making, that these drugs, every single one of these drugs that's effective against BCR-ABL is also highly effective at making normal ABL not function. And normal ABL's there in our body to do things. And there's things it's supposed to be doing. And when you've been on these drugs for years and years, your body gets used to not having it there. And so there are things that it may, other kind of parallel pathways to the ABL, that it would turn on and start using. And so when you stop inhibiting the ABL, all of a sudden you've got sort of double signaling along those lines, because the backup pathway is all turned on and now ABL's suddenly turned back on. And that can knock things out of whack. And for some people, as the caller had mentioned, that can manifest as really just kind of really achy joints and muscle aches and things like that. In general, we find that with supportive care, we can get people through that. But if in general as well, if that is becoming unmanageable, typically getting back on the original drug will resolve those symptoms.
Sure. And we are hearing a lot of side effect management questions. A lot of folks are mentioning that they have extreme fatigue, bone pain,
Yep.
Sleeplessness. You mentioned that there's a possibility to really mitigate some of these side effects. So how do you assist your patients in helping side effects?
So the fatigue, honestly, that one, I have never really come across a great way to manage. I mean, that one, the best management plan that I have in mind, well, the two best management plans I have in mind for that is, one, get to a TFR, since that, that not being on the drug will eliminate that. And then if you can't get on a TFR, then to reduce the dose to the lowest possible to still control the disease, but have as minimal in the way of side effects. In terms of joint pain, things like that, my pharmacists have a bunch of sort of, side remedy type stuff, I would say. One of them is just, a spoonful of mustard, so mustard seed. People have found can be helpful. Various anti-inflammatories. But yes, it's that can be burdensome. And again, as we demonstrated off of the last study, the side effects that people have from these are real, and they do get better when people get off. And so the goal, wherever possible, is to get people off. And again, getting back to, each person's situation is different. Getting back to that earlier caller, for some folks, it's worse being off than being on. And then, so if their better outcome is to stay on treatment, then I think it's appropriate to stay on treatment.
And Asha is asking if you're saying that, do all physicians really have you on treatment for 3 years before you can attempt to go off treatment?
That is the recommendation. Again, I mean, an individual physician can do what they choose to do. I mean, these are not sort of FDA requirements or anything like that. But that's the guidelines. We actually are in the midst of running a second treatment-free remission trial. And if there are those on the call who have tried a treatment-free remission and failed, they should look on the Cure CML consortium website for one of the member centers to see if you can get to that study at one of those centers. For that study, it is required that the first TFR be done right. So if somebody stops treatment after being on treatment for less than 3 years, then they would not be eligible for the study. If someone stops treatment when their levels were not low enough for at least that 2-year period, they would not be eligible for the study. And then if they start treatment again when their molecular numbers have not gotten above 0.1%, they would not be eligible for the study. And so again, in general, that is what our current recommendations are as to the best chances of success. Somebody might be able to make it work at, quicker and shorter. I mean, anecdotally, I've had situations where a patient of mine was not yet eligible formally for a TFR, but found herself pregnant unintentionally, but wished to continue the pregnancy. So we stopped her treatment, and she then had a recurrence. We didn't start treatment again until after her pregnancy was done, but it was not successful. Again, it's anecdotal information, but in general, I would recommend that people follow the plan as listed. I mean, the other thing which I could say is that in the totality of studies about treatment-free remission, the best indicator that somebody's going to have a successful treatment-free remission is the length of time they were on treatment before they started the treatment-free remission. So being on for 7 years or for 10 years, you have better success rates. Now, again, practically speaking, waiting another 4 or 5 years after you make it to the initial cutoff of being eligible, it's probably not worth it. I am not saying to my patients they need to wait longer than 3 years, but I do insist that people wait at least 3 years before we try a TFR.
Thank you. And our last question today, Jean is asking, is there a potential cure on the horizon?
Again, I would really frame treatment-free remission as cure. I mean, if somebody's successful in achieving a treatment-free remission and they're 10 years out and still the level of the BCR-ABL that they have is at a level that they are safe from blast crisis, they are cured. The disease is no longer part of their existence. I mean, other than needing to monitor again. And how often do we need to monitor somebody who's 5 years on a TFR, 10 years on a TFR? Again, our current guidelines say every 3 months, but practically speaking, with my patients like that, I will space out to every 6 months to once a year. I still think probably, I don't think there's anybody I would say that they shouldn't get tested at least once a year, because we just don't know. It might pop back up. And if we never see it pop back up, that's great. But if we catch it and be able to get them back on treatment before they show up again with a super high white count and symptoms from their disease, it's better to have known.
Thank you. And thank you so much, Dr. Thompson, for volunteering your time and your expertise with us today. I know that we did not get to all of the questions, and if we were not able to get to your question today, or you want more information or resources, you may speak to one of our information specialists at 1-800-955-4572 from 9 a.m. to 9 p.m. Eastern Time, or you can reach us at email at bloodcancerunited.org/contact us. You may also reach out to one of our clinical trial nurse navigators in our clinical trial support center. Our nurse navigators are able to identify CML clinical trial options for you and your unique situation. And if you haven't already done so, please make an appointment with one of our nutrition educators. They're registered dietitians that can answer questions for patients and caregivers with any type of cancer, and they are free consults. And you may contact them by visiting bloodcancerunitednutrition.org, or you can contact them toll free at 877-467-1936. And Blood Cancer United does offer financial assistance to help individuals with blood cancers. So for more information, you can visit bloodcancerunited.org/finances. And we also have started a medical debt case management program that provides one-to-one in-depth personalized support to empower patients to address their medical debt. And they may be reached at bloodcancerunited.org/medical debt or by calling 833-507-8036, 8:30 a.m. to 5 p.m. Eastern Time, Monday through Friday. Webcast participants, please complete the program evaluation now as it's flashed at the bottom of your screen. And phone participants, you can complete the evaluation at bloodcancerunited.org/eval. That's /EVAL, or complete the form included in your mailed packet. For the professionals on this call, please note that there is no continuing education credits offered for this program. As a reminder, you can download and print the slides as well as view today's program from our website at bloodcancerunited.org/programs. And again, thank you so much for our supporter for this program, Novartis Pharmaceuticals Corporation. Dr. Thompson, thank you again for volunteering your time with us today. And on behalf of Blood Cancer United, thank you all for joining us. Goodbye, and we wish you well.
This concludes today's telephone and web education program. Please remain connected to complete the evaluation. Thank you for your participation.